In this video, we are going to be looking at the topic Rumination Syndrome. Hi, I'm Sharon. I'm working as an assistant professor at MMM College of Nursing. The following are the objectives that we'll be addressing in this video. Rumination Syndrome is a functional gastrointestinal disorder which refers to effortless regurgitation of recently ingested food from the stomach back into the oral cavity in the absence of an organic disease. The regurgitation usually occurs within the first 15 minutes after the completion of a meal. A simultaneous remastication and expectoration or reswallowing of the indigested food is commonly observed and can continue for up to 2 hours after each meal. It can be present in both children and adults. Rumination syndrome is classified as a functional gastrointestinal disorder by the Rome-4 criteria and as an eating disorder according to the Diagnostic and Statistical Manual of Mental Disorders, that is DSM-5. Often misdiagnosed as gastroesophageal reflux disease or vomiting, which results in unnecessary testing and treatments, leading to delay in therapies that will help alleviate the problem. Let's look at the etiology of rumination syndrome. It is multifactorial. The exact causes are poorly understood. Let's look at the risk factors. That is emotional neglect in infants, emotional stress, presence of mental health diagnoses such as obsessive compulsive disorder, anxiety, depression, adjustment disorder, post-traumatic stress disorder, and attention deficit hyperactivity disorder, that is ADHD, developmental delay, fibromyalgia, which is a disorder characterized by widespread musculoskeletal pain accompanied by fatigue, sleep, memory and mood issues, and rectal evacuation disorder. Now, let's look at the epidemiology. The exact prevalence and incidence are uncertain as different diagnostic criteria are used to diagnose depending upon the clinical setting. It is likely severely underdiagnosed as well. Patients take years to be accurately diagnosed and tend to see numerous physicians, leading to sparse, inaccurate data. Patients commonly report vomiting, abdominal pain, and symptoms compatible with avoidant or restrictive food intake disorders, making the diagnosis particularly difficult. This syndrome exists in all age groups. Rajendrajit et al. Indicated in a Sri Lankan population based study with more than 2,000 children aged 10 to 16 years a prevalence of 5.1% evenly distributed between boys and girls. It appears to be less common in the general adult population, approaching approximately 1%. Approximately 20% of adults not responding to proton pump inhibitors displayed a rumination profile on postprandial high-resolution impedance manometry. Histopathologically, mild eosinophilia, especially the gastric antral eosinophils, and a higher number of intraepithelial lymphocytes, including mast cells, were found. These underlying histological changes suggest a possible inflammatory component in patients with rumination syndrome. However, the exact mechanism and molecular pathways involved remain unknown. Let's look at the pathophysiology of rumination syndrome. Normally, the upper esophageal sphincter tone and the lower esophageal sphincter tone is normal, whereas in GERD, there is normal upper esophageal sphincter tone and decreased lower esophageal sphincter tone, but the pressure inside the stomach is normal. But because of this decreased tone in the LES, it causes regurgitation of food. Whereas in rumination syndrome, there is relaxed upper esophageal sphincter and relaxed lower esophageal sphincter, but there is increased intragastric pressure which causes the food to go back up. And you can compare the waves between the intraesophageal pressure wave and intragastric pressure wave here. And the variances pressures can also be noted. Coming to the clinical manifestations, we can see that because of the increased intragastric pressure and relaxed low esophageal sphincter, acid and stomach contents flow back up into the esophagus, and the following symptoms will result. Patient can have bad breath or halitosis, constipation, nausea and vomiting, diarrhea, bloating, tooth decay, weight loss, that is malnutrition, stomach aches, dry mouth or lips, and this can also lead to electrolyte imbalance. Let's look at the diagnosis. The assessment of potentially underlying eating disorders has to be done, such as bulimia nervosa and anorexia nervosa, endoscopic and or CT angiography to be done to exclude mechanical obstruction. Let's look at the next diagnostic measure, that is high resolution esophageal manometry with impedance testing. This study can confirm rumination syndrome in both children and adults. Postprandial intragastric pressure is usually about 25 to 30 mmHg in patients with rumination syndrome. So this picture shows how the pressures are varying over the period of time from upper esophageal sphincter, the esophagus, to the lower esophageal sphincter and the stomach. The next diagnostic measure is electromyography of the abdominothoracic muscles. This shows a characteristic spiking of activity during episodes of rumination. Historically, this study was employed in the diagnosis of this condition. Gastric emptying studies and pH studies is recommended if clinical symptoms are atypical and other underlying conditions such as refractory, GERD, or gastroparesis have to be excluded. Next, let's look at the Diagnostic and Statistical Manual of Mental Disorders, DSM-5 criteria. In this, repeated regurgitation of food for a period of at least 1 month is a sign. Regurgitated food may be rechewed, reswallowed, or spat out. The repeated regurgitation is not due to an underlying general medical condition, example GERD, pyloric stenosis, etc. The behavior does not occur exclusively in the cause of anorexia nervosa, bulimia nervosa, binge eating disorder, or avoidant or restrictive food intake disorder. If occurring in the presence of another mental disorder, that is, intellectual developmental disorder, or general medical condition, including pregnancy, it is severe enough to warrant additional clinical attention. Let's look at the Rule 4 criteria in adults. Must include all of the following, that is, persistent or recurrent regurgitation of recently ingested food into the mouth with subsequent spitting or remastication and swallowing. Regurgitation is not preceded by retching. Criteria fulfilled for the last 3 months with symptom onset at least 6 months before diagnosis. The supportive aspects include effortless regurgitation events, and they are usually not preceded by nausea. Regurgitant contains recognizable food that might have a pleasant taste, and the process tends to cease when the regurgitated material becomes acidic. Let's look at the same criteria in children, especially in neonate toddler. Must include all of the following for at least 2 months. There should be repetitive contractions of the abdominal muscles, diaphragm, and tongue. Effortless regurgitation of gastric contents which are either expelled from the mouth or rechewed and reswallowed. 3 or more of the following, that is, onset between 3 and 8 months, does not respond to management for GERD and regurgitation, unaccompanied by signs of distress, and it does not occur during sleep and when the infant is interacting with individuals in the environment. In children or adolescents, must include all of the following for at least 2 months. That is, repeated regurgitation and rechewing or expulsion of food that begins soon after ingestion of a meal. It does not occur during sleep and not preceded by retching. After appropriate evaluation, if the symptoms cannot be fully explained by another medical condition, an eating disorder must be ruled out. The following are the differential diagnoses for rumination syndrome. Let's look at the treatment for rumination syndrome. Patients can be taught diaphragmatic breathing, augmentation strategies, that is general relaxation and thumb chewing, and cognitive behavioral therapy. In pharmacotherapy, baclofen 10 mg 3 times a day can be given as it counteracts transient lower esophageal sphincter relaxation by increasing the basal LES pressure, thereby limiting regurgitation episodes. Spiron can be given as it has positive gastric fundus relaxation properties. The complications of rumination syndrome are mental and physical distress affecting the quality of life, weight loss, electrolyte disturbances, dental damage, accompanying anxiety, depression, and somatization, necessitating long term cognitive behavioral therapy to help with symptoms. The following are the references for this topic. Thank you.